തുടങ്ങാം അല്ലേ?
എന്താ അറിയാവോ, അതൊരു നോക്കാം പാപ്പ. എന്താ അറിയാവോ, കുറച്ച് പേരിപ്പോ കറക്റ്റ് ഷാർപ്പായതേ ഉള്ളൂ. കഴിഞ്ഞ മണിയൊക്കെ തുടങ്ങിയപ്പോ 4 മിനിറ്റ് താമസിച്ചു. വെച്ച് കഴിഞ്ഞാല് നമ്മളൊരു 4 പേര് കൂടെ രാവിലെ ചിലർക്ക് തുടങ്ങുമ്പോ നെറ്റിന്റെ പ്രോബ്ലം എന്നൊക്കെ പറഞ്ഞേ, ആളുകൾക്ക് ശരിക്കും പറഞ്ഞാൽ ഷാർപ്പായിട്ട് സ്റ്റാർട്ട് ചെയ്യണം. അതാണ് ഇതിന്റെ ശരി. പക്ഷെ പലപ്പോഴും നമുക്ക് അതിന്റെ ആ ഒരു 5-6 പേര് കയറിയില്ലെങ്കിൽ നമ്മൾ എന്തിനാണോ ഇത് നടത്തുന്നത് അതിന്റെ പ്രയോജനമില്ലാതായിപ്പോ. അതാണ് സ്ഥിരം വരുന്ന ആൾക്കാരൊക്കെ കയറി വന്ന്.
Good evening, sir.
Good evening. Good evening. Yes.
Good evening, sir.
Good evening, Mahadevan sir.
Good evening. Welcome. Nice, nice.
അപ്പൊ നാളെ കൊല്ലത്ത് പോകുന്നുണ്ടോ?
സാറ് പോകുന്നുണ്ടോ?
ഈ എന്ത് പരിപാടി ഉണ്ടെങ്കിലും ഞാനും അതേ കൂടെ അങ്ങ് പോകും.
പോയില്ലേ? ഞങ്ങളുടെ സാർ ഒരു ബാച്ച് റീയൂണിയന്റെ ഒരു മീറ്റിംഗ് നാളെ, അതുകൊണ്ട് പോവാൻ പറ്റുമോ? ഞങ്ങളുടെ
റീയൂണിയന്റെ മീറ്റിംഗ് ആണോ, അതിന്റെ പ്ലാനിങ് ആണോ?
ആക്ച്വലി അതിന്റെ എന്തൊരു സ്കിറ്റിന്റെ റിഹേഴ്സൽ ആണ്. അതിലെല്ലാരും പിടിച്ച് ചേർത്തിട്ടുണ്ട്. നെക്സ്റ്റ് വീക്ക് ആണ് സാറേ.
അഭിനയിക്കാൻ ഡൗട്ട് വരാണ്ടേ
അതെ അതെ, എല്ലാരും കമ്പൽസറി ആയിട്ട് ഒരു പ്രോഗ്രാമിൽ ചേർത്തിട്ടുണ്ട്. അപ്പൊ അത് IMA ഹാളിൽ വെച്ച് പ്രാക്ടീസ് ചെയ്യുവാ നാളെ. അപ്പൊ അത് വിടാൻ പറ്റില്ല. അങ്ങനെ നല്ല പ്രോഗ്രാം ആയിരിക്കും തോന്നുന്നല്ലേ നാളെ കൊല്ലത്തെ യങ് ഓഫ്താൽമോളജിസ്റ്റ്.
നല്ലൊരു ഇതാണ് എന്ന് വെച്ച് കഴിഞ്ഞാല് കുട്ടികളെ നമ്മുടെ കുട്ടികൾ എങ്ങനെ ചെയ്യുന്ന ഒരു വലിയ സന്തോഷമല്ലേ. ഇതിന് വിളിച്ചത് ആദ്യം മറ്റേത് കൊല്ലം എന്ന് വെച്ച് കഴിഞ്ഞാൽ രാജകുമാരൻ വിളിക്കും, JP വിളിക്കും. ഇത് ആദ്യം നമ്മുടെ ഇവര് ദിവ്യ വിളിക്കുന്ന, അത് കഴിഞ്ഞപ്പോ നമ്മുടെ പാർവതി ഒരു കാര്യത്തിന് വിളിക്കുന്ന, അത് കഴിഞ്ഞപ്പോ നമ്മുടെ ചൈതന്യെന്ന് ഇപ്പൊ പോയ ഒരു കുട്ടിയുണ്ട്, അവര് വിളിക്കുന്ന. അപ്പൊ എല്ലാം ഇങ്ങനെ ആ ഒരു ലെവൽ ആൾക്കാരാണ്. അപ്പൊ അവരുടെയൊക്കെ ഒരു സെൻസ് ഓഫ് ഇൻവോൾവ്മെന്റ് വെരി ഹാപ്പി.
ഇന്നലെ അനീഷ് വന്നിരുന്നു, അവരുടെ ഗെറ്റ് ടുഗദർ ആണ്. അപ്പൊ വീട്ടിൽ വന്നിരുന്നു. അപ്പൊ ഓൾറെഡി 178 രജിസ്റ്റേർഡ് വന്നു. 178. അപ്പൊ ഞാൻ ചോദിച്ചു ഹാള് ശരിയായിരിക്കുമോ? 200 പേര് കൊള്ളുമെന്ന് ആ ഹാളില്, മിക്കവാറും 200 പേരും വരും.
അല്ല മതൻസല, കഴിഞ്ഞ തവണത്തെ സ്ഥലമല്ല ഇത്. നമ്മുടെ പഴയ അവിടുത്തെ നമ്മുടെ റാബീസ് തന്നെയാണ്. കഴിഞ്ഞ തവണയാണ് കുറച്ചുകൂടെ ഒരു 4 സീസൺസ് ഓൾ സീസൺസ് പറഞ്ഞൊരു കഴിഞ്ഞ തവണ. അത് കുറച്ചുകൂടെ റാബീസ് ആയതുകൊണ്ട് പ്രശ്നമൊന്നുമില്ല. തുടങ്ങാം മതൻസലെ, എലിസബത്ത് നമുക്ക് തുടങ്ങാം. 34
പിന്നെ സ്റ്റാർട്ട് ചെയ്തോളൂ. പാർട്ടിസിപ്പൻസ് അതൊക്കെ വന്ന് ജോയിൻ ചെയ്തോളൂ. പിന്നെന്താ,
എലിസബത്ത് ഒരു വാക്ക് പറഞ്ഞിട്ട് തുടങ്ങണം.
Sure, sir. Today we are going to present a Krishna case presented by Dr. Mohasina from Chaitanya Hospital, and case discussion by Dr. Papa Madam. So, sir, can we start? Madam?
Yes, okay. Start ചെയ്തോളൂ.
Mohasina start ചെയ്തോളൂ.
Okay, ma'am. Okay, ma'am.
മോസീന ഷെയർ ചെയ്യണേ.
Ma'am. Ma'am. Good evening, sir and ma'am. I'm presenting a case of 50-year-old male, Mr. Samsung PC, coming from Trivandrum. He presented to our OPD on 15th.
സ്ലൈഡ് ഷോ ആയില്ല, മറ്റേ മോഡിലാ കിടക്കുന്നേ.
സ്ലൈഡ് ഷോ മൂവ് ചെയ്യുന്നില്ല. സ്ലൈഡ്
മൂവിന്ന് മാത്രമല്ല, സ്ലൈഡ് ഷോയുടെ മോഡിലല്ല കിടക്കുന്നേ, മറ്റേ
സ്ലൈഡ് ഷോയുടെ മോഡിലല്ല.
ആരെങ്കിലും ഉണ്ടോ അവിടെ ഹെൽപ്പ് ചെയ്യാന്?
മോഹസീന, മോഹസീന,
Probably somebody is out to help her, probably.
അതെ അതെ, somebody has to help her. അതെ, ഒറ്റയ്ക്ക് പറ്റത്തില്ല.
റേഞ്ച് ഇല്ലാന്ന് തോന്നുന്നു അല്ലേ സർ? റേഞ്ച് ഫ്രീസ് ആയ
അല്ല, അവിടെ നെറ്റിലൊന്നും വിഷയമൊന്നും യൂഷ്വലി വരത്തില്ല. എനിക്ക് തോന്നുന്നു പ്രോബ്ലി എത്തിയവരാരെങ്കിലും കാണുമായിരിക്കും.
മോഹസീന, അത് സ്ലൈഡ് ഷോ ആക്കാമോ?
മാം. സ്ലൈഡ് ഷോ ക്ലിക്ക് ചെയ്താൽ പോരെ മുകളില്?
സ്ലൈഡ് ഷോ എന്ന് പറയും, നമ്മുടെ സ്ക്രീൻ സ്ലൈഡ് ഷോ എന്ന് പറയും.
ഓക്കെ, സ്ലൈഡ് മാറിയിട്ടുണ്ട്.
ഇപ്പൊ
വന്നോ?
സ്ലൈഡ് ചേഞ്ച് ചെയ്യുന്നുണ്ട്, പക്ഷെ ഫുൾ സ്ക്രീൻ വരുന്നില്ല.
ഇപ്പൊ ഫുൾ സ്ക്രീൻ ആണ് ചേച്ചി.
മാം ഇപ്പൊ ഫുൾ സ്ക്രീൻ ആണോ? അല്ല
നമ്മളുടെ സ്ക്രീനിൽ ഫുൾ സ്ക്രീൻ ആണെന്ന് പറയാ ചേച്ചി.
മാം ഇവിടത്തില് ഫുൾ സ്ക്രീൻ കാണിക്കുന്നു. എന്നാ ഓക്കെ, പ്രസന്റ് ആയിട്ടല്ലേ സാർ?
കണ്ടിന്യൂ ചെയ്യട്ടെ, കൺഫ്യൂഷൻ ഉണ്ടെങ്കിൽ കണ്ടിന്യൂ ചെയ്യട്ടെ. ഓക്കെ,
കുഴപ്പമില്ല, അതെ, ഡിലേ ചെയ്യണ്ട, വന്നോട്ടെ, കുഴപ്പമില്ല.
മാം ഇപ്പം ഇവിടെ സിസ്റ്റത്തില് ഫുൾ സ്ക്രീനാ വന്നേക്കുന്നത്. സാരമില്ല, യു കൻ സ്റ്റാർട്ട്.
അതെ, ഡോണ്ട് വറി, പ്ലീസ്.
Okay. I am presenting a case of 50-year-old male, Mr. Samsung PC, coming from Trivandrum. He presented to our OPD on 15th of June 2022. His presenting complaints were blurring of vision in right eye since 3 weeks. History of presenting complaints was patient was apparently normal 3 weeks back when he noted diminution of vision in right eye, which was sudden in onset, painless, noted on waking up from sleep in the morning, which lasted for 3 to 2 hours and resolved completely. Later, again, he developed sudden painless diminution of vision in right eye 2 weeks back, which remained as such since then. There was no history of any ocular trauma, no history of pain, redness, photophobia, or discharge, no history of transient obscuration of vision in the past, no history of flashes or floaters, no history of headache, nausea, and vomiting. Past history, no history of ocular trauma, surgery, laces, or...
No, slide is not moving. Slide is not moving. Slide is not moving.
സ്ലൈഡ് ഫസ്റ്റ് സ്ലൈഡിൽ തന്നെയാ മോഹസീന ഇരിക്കുന്നത്.
Second slide. നെയിം ഏജ് സ്ലൈഡിൽ തന്നെയാണ് ഇരിക്കുന്നത് ഇപ്പോഴും.
Previous slide.
Now it has become slide show full.
ഇപ്പൊ വന്നോ മാം? ഇപ്പൊ ശരിയായിട്ടുണ്ട്.
ശരിയായിട്ടുണ്ട്. ഇതെല്ലാം At every episode this happens, initially, but now it's all getting corrected, no problem. Very good.
Okay, sir. Okay.
Yeah, fine.
Past history, no history of ocular trauma, surgery or laces or injections, no history of glaucoma. Medical history, patient is a non-diabetic and hyperlipidemia under diet control for 4 years. Patient was recently diagnosed as hypertensive. Personal history, mixed diet, normal bowel and bladder habit, normal sleep and appetite, no drug allergy, not a smoker or alcoholic. General examination, he was moderately built and nourished, conscious, well-oriented in time, place and person. There was no pallor, icterus, clubbing, cyanosis, no pedal edema, no generalized lymph node enlargement, no evidence of any skin rash, nodules or oral ulcers. Vitals, pulse was 82 per minute, regular rhythm, normal volume. Peripheral pulsations were normal. Carotid pulsation, bruit was noted in right side, where left side was felt normally. BP was 140/100 mm of mercury in right upper limb in sitting position. Respiratory rate was 14 per minute and he was febrile. Systemic examination, cardiovascular system S1, S2 heard, no murmur. Respiratory system, air entry bilaterally equal, normal vesicular breath sounds heard. GAT per abdomen soft and no organomegaly. CNS examination, higher mental function was normal. Cranial nerve examination, all the cranial nerves were normal. Musculoskeletal system was also within normal limits. Ocular examination, he was orthotropic in primary gaze. There was no facial asymmetry, no ptosis, proptosis, nystagmus or strabismus, no head tilt, face turn or chin elevation. Ductions, versions and versions were normal. His visual acuity, uncorrected visual acuity was in right eye CF 2, counting fingers 2 meters, left eye 624. Near vision in right eye was less than N36, in left eye was N6. Best corrected visual acuity. Dilated retinoscopy with 0.8% tropicamide with 2/3 meter was working distance showed. Minus 0.25 D sphere at 90-degree axis and minus 3 D sphere at 180-degree axis in right eye. In left eye, minus 0.25 D sphere at 90-degree and minus 3 D sphere at 180-degree. Acceptance was right eye, counting fingers 2 meter with minus 1.75 D sphere and minus 2.75 D cylinder at 70-degree axis, improving to 636 and N36. In left eye, 624 with minus 1.75 D sphere and minus 1.75 D cylinder at 90-degree axis, improving to 66 N6. Anterior segment examination of right eye showed lid and adnexa was normal, conjunctiva was normal, cornea normal size, shape and luster, AC von Herix grade 4, no AC reaction, iris normal color and pattern, no neovascularization of iris noted, pupil direct was sluggish, conjunctional right reflex was brisk, no RAPD, lens showed early cataractus changes, anterior vitreous space was clear. Intraocular pressure was 14 millimeter of mercury at 9:20 AM by Goldman applanation tonometry. Then anterior segment examination of left eye showed lid and adnexa was normal, conjunctiva was normal, cornea showed normal size, shape and luster, anterior chamber von Herix grade 4, no AC reaction, iris normal color and pattern, pupil direct light reflex was brisk, conjunctional light reflex was sluggish, lens showed early cataractus changes, anterior vitreous space was clear, IOP was 14 mm of mercury at 9:25 AM by Goldman applanation tonometry. Fundus examination of right eye, distant direct ophthalmoscope shows clear media. Fundus examination of right eye with 90D and periphery with indirect ophthalmoscopy showed clear media. Optic disc showed disc margins and neuroretinal rim was not clearly made out. There was peripapillary superficial hemorrhages extending over optic disc margin. A patch of pale area noted between macula and disc of 2 disc diameter, which was suggestive of retinal whitening. 2 disc diameter area of retinal thickening noted over macular area, suggestive of macular edema. Foveal reflex was absent. Dilated tortuous veins with arteriovenous ratio of 2:4. Arteries are narrowed with AV crossing changes. Sclerosed vessels noted in nasal quadrant. Whitish fluffy lesions with ill-defined margins noted adjacent to the disc infranasally, which was suggestive of cotton wool spots. Multiple dot and blot hemorrhages noted in all quadrants, extending to periphery in all quadrants, suggestive of deep retinal hemorrhages. Superficial flame-shaped hemorrhages was noted in superior nasal quadrant. Fundus diagram of right eye. Fundus examination of left eye. Distant direct ophthalmoscope shows clear media. Fundus examination of left eye with 90D and periphery with indirect ophthalmoscopy showed clear media with horizontally oval disc with distant disc margin with cup disc ratio of 0.6:1. Neuroretinal rim was pink and healthy with inferior rim greater than superior rim, which was greater than nasal rim, which was greater than temporal rim, with nasalization and bionating of vessels. Peripapillary area appears normal. Origin of vessels was normal with arteriovenous ratio of 1:3. There was generalized arteriolar narrowing present with AV crossing changes. Yellowish discrete lesion noted in superior temporal quadrant suggests
range word.
Connectivity issues. We can't hear you.
Mohasina.
ma'am.
Yes, now we can hear. So the
Okay.
previous slide, when you said we can't hear.
Okay, sir. Fundus examination of left eye.
And the next slide, That also we had seen. Next.
This.
Yeah, now left eye. Now you can go on. Yeah.
Okay, sir. Fundus examination of left eye with 90D and periphery with indirect ophthalmoscopy showed clear media, horizontally oval disc with distant disc margin with cup disc ratio of 0.6:1. Neuroretinal rim was pink and healthy with inferior rim greater than superior rim, which was greater than nasal rim and which was greater than temporal rim with nasalization and bionating of vessels. Peripapillary area appears normal. Origin of vessels was normal with AV ratio of 1:3. Generalized arteriolar narrowing present with AV crossing changes. Yellowish discrete lesion noted in superior temporal quadrant suggestive of brucine 2 disc diameter away from fovea. Areas of RPE atrophy noted in nasal and infero-temporal quadrant. Macula foveal reflex was present. Fundus diagram of left eye. Summary: a 50-year-old gentleman, known case of diabetes mellitus dyslipidemia, recently diagnosed as hypertensive. He presented with transient, sudden onset painless diminution of vision in right eye 3 weeks back after waking up in the morning, which resolved completely after 2 to 3 hours, following which patient developed sudden painless diminution of vision in right eye 2 weeks back, which persisted as such. On examination, visual acuity was 636, N36 in right eye and 66, N6 in left eye. Anterior segment examination of both eye were within normal limit. Fundus examination of right eye showed disc margins which were masked by peripapillary hemorrhages with cotton wool spots inferonasally, dilated and tortuous veins with arteriolar attenuation in all quadrants and AV crossing changes with scattered deep blood hemorrhages in all quadrants extending to periphery. Fundus examination of left eye showed attenuated vessels with AV crossing changes. Anatomical diagnosis: right eye, central retinal vein occlusion with possible cilio-retinal artery occlusion and macular edema. Left eye, hypertensive retinopathy, grade 1, both eye, early cataract changes. Investigations were done and it was found to be, cholesterol, triglyceride level was found to be high with FBS also high and BP was found to be 140/100. Others, CRP level was mildly elevated with a normal ESR level. Others were within normal limit and carotid Doppler showed there is a hypoechoic plaque measuring 13.7 into 2.6 millimeter in the right carotid bud, causing 43% of luminal narrowing.
No, I think you should have given a provisional diagnosis before going into the investigations.
Okay, sir.
That's the general rule when you do it in the examination.
Okay, sir.
And then, of course, you can go to all these investigations. So, Papa,
മറ്റേ ആ ഇൻവെസ്റ്റിഗേഷൻസിന് മുമ്പ് നമുക്ക് ഡിസ്കഷൻ തുടങ്ങാം. From here the investigation should.
After that only, okay. So first slide കാണിക്കോ, history of presenting complaints.
Okay, ma'am.
No, the history of presenting. Okay, you said 3 weeks back there was an incident and lasted for 2 to 3 hours. So how will you explain that? Then again,
Transient vision loss.
is it last for 2 to 3 hours?
After waking up from sleep. Amaurosis.
Amaurosis. Is it last for 2 to 3 hours? Amaurosis.
Amaurosis fugas can be of different causes. It can be due to embolic cause, or it can be due to hemodynamic cause, ocular, then neurological cause, and it can be idiopathic. In embolic cause, it can be due to carotid artery emboli.
I'm asking about the duration. Usually what is
how many amaurosis, how long it will last?
Usually in few
How
seconds.
long it will last?
If it is lasting for few seconds, it can be suspicious of papilledema. Then few minutes, we can think of vein occlusion and artery occlusion. For hours, usually migraine.
Okay. Okay. Then next slide. Okay, so past history, there is no other ocular history. Now, at the slide, next slide. Okay, suppose this is a 40-year-old male.
Okay, ma'am.
Okay, what are the things you will ask in the medical history?
40-year-old male. We have to think of other causes like any hypercoagulability disorders, then vasculitis, any cause for any myeloproliferative diseases, increasing blood viscosity.
Okay.
Then features of vasculitis, Behçet's SLE.
That you were telling, no, ulcerations, you were mentioning that. Okay, next slide. Okay. Next slide. Okay, so treatment history, is it important? Any drug intake, is it important?
Oral contraceptives.
Okay, suppose it's a female, very young patients, or hormone replacement therapy, patient on chemotherapy. So it is important in young patients. Okay. So next slide. Okay. And before that, any past history of any recent viral infection, is it important? Like any vaccine? Recently, one epidemic. So is it
for COVID?
Yes, that is also supposed to be very important. It can cause thromboembolic episodes. Okay. History of COVID vaccine, all those things are important.
Okay.
Then this slide, I think, carotid pulsations, bruit noted on right side. How will you look for carotid bruit?
We have to palpate using the index and thumb finger.
Where will you palpate?
Temporal to the tracheal, lateral to the tracheal cartilage.
Trachea is a long structure, which part of the
second, third,
second level? Where is the cartilage? Oh, that is for okay, that is for carotid pulsations. Bruit, how will you find out the carotid bruit?
we have to auscultate near that where we get pulse temporal to the
Auscultate, what will you hear? You will hear something now, say, murmur like thing. So is it important, this carotid buoy? What is the importance of carotid buoy? Whether it always detects obstructive disease, or can it be normal also, or is it seen in some other conditions also? Because you have highlighted carotid buoy, that is why I am asking.
carotid buoy, it can be associated with systemic risk factors. There is hypertension, diabetes, hyperlipidemia.
That is risk factors, no? In which all conditions you get. One is carotid occlusive disease. No? So
Okay.
it's not seen in all patients with carotid occlusive disease also. Only in 50%. Okay. So even in this patient, you are telling some 43 some percentage, no? You are getting a carotid buoy. So it is not that specific or sensitive, but still it's a finding. Okay. So he is hypertensive, which is uncontrolled. It's 140 by 100. No, it's uncontrolled. Next slide. You stop sharing, Aipoyo. Okay. At the slide, I think you have to restart sharing. Okay. Move ആവുന്നില്ലേ? It's not moving. ഇയാള് mute ആണെന്ന് തോന്നുന്നു. I think you are mute. Move ആവുന്നില്ലേ slide?
Slide move ആവുന്നുണ്ട്. ഇപ്പം വരുന്നുണ്ടോ? Personal list.
I can see the first slide. First slide കാണാം.
Probably it is moving, but here it's not moving.
Okay.
Probably you see it moving, but for those on this end, no, it's not moving.
Okay, leave it. So, okay. So why you are saying this is a CRVO with ciliary? What are the signs of ciliary artery occlusion in this patient?
There is a whitening noted in the area between the macula and optic disc.
Okay. So what are the signs of venous occlusion in this patient?
Venous occlusion, there is venous tortuosity and dilatation was there with the AV ratio of 2:4. There was numerous dot and blot hemorrhages and flame-shaped hemorrhages with cotton wool spots seen adjacent to the disc.
Okay, so you were telling some sclerosed vessels nasally. The vessel, which is sclerosed, vein or artery?
Artery, ma'am.
Artery. Okay. And you were telling some hemorrhages are more in one quadrant. Is it significant? You were telling some supratemporal quadrant, more hemorrhages are seen. You were telling that. Okay.
Flame-shaped hemorrhages more.
More in one quadrant. Okay. Yeah. What about the pupil? There is no RAPD, but pupil was sluggish.
Sluggish, ma'am.
And the vision was improving to 6/36.
6/36, ma'am.
Okay. So what type of venous occlusion? Is it ischemic or non-ischemic?
As the vision is 6/36 and no RAPD, probably it is non-ischemic type.
Non-ischemic type. Okay. Then what about the other eye? We were telling some, there was some CD ratio 0.6 horizontal cup and all, no? Is it significant?
Yes, ma'am.
Why?
Ocular cause of central retinal vein occlusion, glaucoma is a cause because IOP rise can predispose to central retinal vein occlusion.
So have you done anything to rule out glaucoma in that eye?
Fields not done.
Okay, so you have to evaluate, you have to
Okay.
evaluate the other eye also. It's important because it's an important ocular risk factor. Okay, so what are the risk factors in this patient? What contributed to venous occlusion and ciliary retinal artery occlusion?
He is a diabetic. He is an hypertensive, which was he detected recently only. He is also a diabetic and hyperlipidemia under diet control, not on any medications. Then
So that contributed to CRVO. So what is the cause for this ciliary retinal occlusion seen with CRVO? What is that mechanism?
in CRVO, distal to the obstruction, there will be venous and capillary stasis, and this capillary stasis will also occur in the ciliary-retinal artery. A ciliary-retinal artery is a low pressure system. This stagnation can cause hypoxic changes in that system also.
So there is
It
no
can
pressure gradient. So it is called a hemodynamic block. There is no pressure gradient for the artery to flow to the capillary bed because the capillary bed is also distended and the pressure is more. Okay. So how this ciliary retinal artery is a branch of?
Posterior ciliary artery. Short
Okay.
posterior ciliary.
Okay.
Short
What is the incidence? What is the incidence?
Incidence. 1/3. 1/3.
1/3. So is it always bilateral or unilateral?
CRVO, this
No, I am asking about the ciliary-retinal artery. Is it unilateral, bilateral, always bilateral, or is it unilateral? In this patient, can you see that in the other eye? Have you looked for a ciliary-retinal artery in the other eye?
present, ma'am.
Undo.
Ma'am.
It can be unilateral. In 60 to 70% cases, it can be unilateral also. Okay. So how this choroidal circulation is different from the retinal circulation? You said it is a low pressure. So
in retinal circulation, there is auto-regulation. Even if BP goes high, retinal vessels can control, but choroidal vessel, there is no auto-regulation. It easily go in for fibrinal necrosis.
Okay, there is no auto-regulation and it is applied by the sympathetics also. And as you said, it is a low pressure. How much the perfusion, what is perfusion pressure?
Perfusion pressure, difference between the IOP and the pressure within the system, that is either in the artery or in the vein.
Mean arterial pressure minus the intraocular pressure. So the perfusion pressure is also low in choroidal circulation. It's around 7 millimeters less than the retinal circulation, and also the auto-regulatory mechanism is not there. So all these contribute to ciliary-retinal artery occlusion in case of CRVO. Okay. So what are the other types of occlusion which can be seen with ciliary-retinal artery? One is CRVO with ciliary-retinal, or any other type?
Other is associated with anterior ischemic optic neuropathy and giant cell arteritis. Then it can also occur alone in other vasculitis.
It can be isolated also. So it can be isolated occlusion, or it can be combined with an anterior ischemic optic neuropathy. Okay, then So can you see cherry red spot in this patient?
No, ma'am.
No, no cherry red spot. No. And you were telling some arteriosclerotic changes, okay? Like AV crossing changes. Still, you are saying it is grade 1. So, how will you grade hypertensive retinopathy?
Hypertensive retinopathy, there will be grade 1, 2 classifications are there, Kate-Wagner and Cheese classification. Grade 1, there will be generalized arteriolar narrowing. Grade 2, generalized arterial narrowing with focal narrowing along with AV crossing changes. Grade 3, it is due to the disruption of the blood retinal barrier. There can be macular edema, hard exudates, and hemorrhages can be seen. Grade 4, along with grade 3 with the optic disc edema.
Okay. So, is it hard exudates which is seen in hypertensive retinopathy? What is the type of exudates commonly seen in hypertensive retinopathy?
Lipoprotein.
Oh no, is it hard exudates or autonomous spots? Soft exudates are more in favor of hypertensive retinopathy. So these AV crossing changes are seen in grade 2. How will you grade the arteriosclerosis?
Arteriosclerosis initially, grade 0, no changes. Grade 1, there will be broadening. Broadening of the arterial reflex. Grade 2, broadening with AV crossing changes. Grade 3, copper wiring, and grade 4, silver wiring.
Okay, grade 1 is generalized, the grade 2 becomes the focal, no? So AV crossing changes are seen in grade
2, ma'am.
But you were telling the diagnosis, I heard somewhere grade 1. Grade 1. So what are the types of AV crossing changes?
It can be salusine.
What is that? Salusine, what is that?
Salusine, where artery crosses over the vein, there will be deflection over the vein. Deflection of.
Normally, okay. The angle is? AV crossing angle is obtuse. So when there is deflection of veins, it's an acute angle. That is salusine. Then what are the other changes, other AV crossing changes?
Then Bonnet sign and gun sign.
What is Bonnet sign?
Bonnet sign is banging of the veins distal to the AV crossing point. And gun sign, tapering of vessels in the both sides of AV crossing changes.
Tapering of vein, okay. Okay. Then dumbbell. Both sides there will be banging. Okay. So other hypertensive grade 2 okay. Suppose this is you can see a cherry red spot. It is a sometimes you can see ciliary retinal artery, if it supplies the whole macula, you can see the cherry red spot. So why there is cherry red spot?
As the fovea is thinned in the retinal area due to retinal edema in the surrounding area, that fovea will be the underlying choroid will appear reddish, giving the appearance of cherry red spot.
Okay, some layers are absent in fovea. Which are the layers absent in fovea?
Ganglion cell layer is not there. It is centrifugally going away from the fovea.
Okay. Then, so what are the findings you see in an incomplete artery occlusion? Suppose I am saying this is an incomplete occlusion because you can see, or is it a reperfusion? the occluded artery has started perfused because of the hemorrhages. How will you counter that? This is not a CRVO. I am saying this is an incomplete occlusion or a reperfusion. Here you can see the veins are very much dilated and tortuous. That you will not find. Reperfusion only the artery is affected. The veins are not affected. Okay. And the AV ratio, some confusion is there. You were telling in the right it is 2:4. And you were telling there is arteriosclerosis. If there is arteriosclerosis, how will you say? Left A you were telling AV ratio is?
The ratio of 1:3, ma'am.
1:3. Right A you are telling?
2:4.
Why 4?
Because the veins are dilated and tortuous.
Veins are dilated and tortuous. And simultaneously you are saying the arterioles are narrowed also. Agane parnille. So it should be 1:4. Okay.
Okay, ma'am.
No. What is the prognosis in this patient?
As it is a non-ischemic type, prognosis is good.
So how will you manage? What are the investigations you are going to do in this patient?
Investigation, initially we have to look for BP, then blood glucose, then cholesterol level. Then we have to do cardiology workup, chest X-ray to look for any features of hypertensive, left ventricular hypertrophy. Then as he is of 50 years old, we can go for other tests also to rule out homocystinemia, thrombophilia, other myeloproliferative disorders and vasculitis workup also, ESR, CRP, full blood count. Then ANA, cardiolipin antibody, anti-lupus antibody.
Okay. So in this patient, which are the findings you got in investigation? Any clues?
Investigation, he was found to be hypertensive. His FBS also was high and triglyceride level was also
uncontrolled diabetes, uncontrolled hypertension. Then
carotid, there was plague also was there.
So how much occlusion you expect to cause an ocular ischemia?
90% of stenosis.
90%. More than 50 is significant.
Okay.
Anything around 70, you can expect ocular ischemia as well as cerebrovascular accidents. Okay. So what are the ocular investigations you have done? We're showing now.
Ocular investigation, we have to look for IOP. Then fundus examination, FFA.
Okay.
FFA, we have.
What are the findings you expect in this patient?
FFA, there is, there will be due to, there can be due to hemorrhages, there will be masked fluorescence. And there will be delayed arteriovenous transit time. As it is a non-ischemic type, capillary perfusion will not be affected much.
In which phase of the FFA you will see the coeloretinal artery?
We will see in the choroidal phase.
Maybe in this patient we may not see because of the occlusion. We may not see. Okay. So you are saying it is a non-ischemic, so you may not get CNP areas in this patient. Suppose it is an ischemic CRVO, you have to look for the CNP areas, and the hemorrhages will show the blood fluorescence, and there will be there is macular edema also. So what is the OCT finding?
OCT showed Line scan of OCT passing through fovea vitreous face appears normal.
അത് സ്ലൈഡ് കാണിക്കാൻ പറ്റുന്നില്ലേ?
കാണാം.
What is happening? ആ സ്ലൈഡ് ഷോയിലോട്ട് പൊക്കേ. What is happening?
അത് അനങ്ങുന്നില്ല എന്ന് തോന്നുന്നു സർ, സ്റ്റക്കായി.
അതില് അങ്ങനെ പാടില്ലല്ലോ. ഈ സ്ലൈഡ് ഷോ ഒന്നുകൂടെ
Okay.
ഒരു hypothetical presentation പോരാ. It should be shown and discussed.
Ma'am, ഇപ്പൊ വരുന്നുണ്ടോ?
ഇല്ല, ഫസ്റ്റ് സ്ലൈഡിൽ നിൽക്കുക.
ഷെയർ സ്ക്രീൻ അടിച്ചായിരുന്നോ?
ഷെയർ സ്ക്രീൻ അടിച്ചായിരുന്നു സർ. യുവർ സ്ക്രീൻ ഷെയറിംഗ് ആണ് കാണിക്കുന്നത്.
ഒന്നുകൂടി ക്ലോസ് ചെയ്തിട്ട്.
ഓക്കെ മാം. ഓക്കെ. മാം ഇപ്പം കാണാമോ?
ഫസ്റ്റ് സ്ലൈഡ് കാണാം. മൂവ് ആവുന്നില്ല അല്ലെ? യു ആർ ഗെറ്റിംഗ് സ്ലൈഡ് ഷോ കിട്ടുന്നുണ്ടോ അവിടെ?
ആ മാം.
ഇവിടെ സ്റ്റക്കാണ് സർ.
You should all be familiar with these gadgets also. That's also important in presentation. Way of presentation and discussion is important, and these things are also important. Okay, right.
That's the problem with the modern days, especially online thing.
Okay, I think I can. We're discussing the OCT.
OCT findings.
OCT vitreous face appears normal. Foveal contour is altered with intraretinal thickening was noted. Inner retinal layers was distorted. Hyperreflectivity of inner retinal layers between macula and optic disc, which was suggestive of cilioretinal artery occlusion. Presence of intraretinal fluid noted, which was suggestive of cystoid macular edema. Presence of subretinal fluid suggestive of submacular detachment, and choroid appears normal.
Okay. So what is the central foveal thickness?
Normally 250, 240.
In this patient, what is the CFT value?
That's nearly 450.
450. Okay. So this inner layer hyperreflectivity indicates what?
Reflects edema in ischemic changes.
Because of the artery occlusion. So that is the sign of artery occlusion you see in the OCT. Okay. What are the signs of venous occlusion in the OCT?
There was presence of edema.
What type of edema? What type of edema you were describing?
Cystoid macular edema.
You can see cystoid macular edema along with the submacular detachment. So all these are due to the macular edema of vein occlusion.
Okay.
Right. The other OCT is normal?
Normal, ma'am.
Have you done an OCTA in this patient?
Not done, ma'am.
Not done. So what do you expect? What will you see? Suppose you have done an OCTA. What are the things you will look for?
In Octa, we should look for the cilioretinal artery.
Cilioretinal artery.
There will be venous dilatation, tortuosity can be seen.
In octile. Octile എന്തൊക്കെയാ കാണുന്നേ?
Foveal avascular zone.
Okay, maybe you can see a widening of foveal avascular zone. And what are the other changes? what are the things you will look in the opta, or which are the different levels of vessels in the retina?
Superficial capillary plexus, deep
Ah.
capillary plexus.
Mm.
In superficial capillary plexus and deep capillary plexus, they will be showing dilatation.
Dilatation ആണോ കാണുന്നത്?
Due to
ഈ
stagnation.
occlusion വരുമ്പോ എന്താ വരുന്നത്? Capillary plexus dilate ചെയ്യുകയാണോ ചെയ്യുന്നത്?
Stagnation of blood.
Mm.
There will be capillary non-perfusion.
Mm. Okay, so disorganized superficial and deep capillary plexus. So where are the superficial capillary plexus located?
Superficial capillary plexus in the nerve fiber layer.
And the deep
And
one
deep
is?
in the inner nuclear layer.
So what is this intermediate capillary plexus? 3 levels of capillary you can see in retina. So superficial, deep, and intermediate is?
Intermediate in the ganglion cell layer.
No, it is also on the inner side of the inner nuclear layer. Outer side is the deep plexus.
Okay.
Okay, what will be the finding in choriocapillaries in this patient? This is ciliary-retinal artery occlusion. Anything in the choriocapillaries?
Choriocapillaries also, there will be decreased perfusion pressure and.
No need. The choriocapillaries will be normal usually. Okay. Okay. So how will you manage? So you have done and you have find out the thing, diagnose sedu. How will you manage?
As this patient's vision is 636 and there is presence of
First thing
macula.
is you have to manage his systemic things.
Okay.
Okay. So you were saying it is everything is uncontrolled. Okay.
The systemic management, strict control of BP, then to be started on anti-diabetic medications and anti-cholesterol lipid lowering agents. Then all the other tests were negative, other causes were negative, CRP and other vasculitis workup were negative.
Then ocular management.
Then as his vision is 636 and he's having macular edema. We should do an FFA to find out any evidence of macular ischemia and the amount of non-perfused areas.
Okay.
Then we can plan for intravitreal anti-VEGF injections.
Okay. So how does it help the patient? Anti-VEGF, how does it help in this patient? Patient with CRVO, with ciliary-retinal artery occlusion. What is its mechanism?
Anti-VEGF, it's a monoclonal antibody against vascular endothelial growth factor. It binds to the, as there is inflammation, there will be more vascular endothelial growth factors act against that VEGF and will decrease the edema.
So it decreases the vascular permeability and also it decreases the inflammatory effect of VEGF. Because there is no neovascularization in this patient. So mainly it is macular edema, that is because of the permeability and the inflammatory component. So VEGF acts against all those things. And you're supposed to have a good prognosis also in ciliary-retinal artery occlusion. Right. So what are the complications? Suppose you are not treating.
Complication, he can go in for a neovascular glaucoma. Then he can turn into as it is a non-ischemic, if he can turn in for ischemic CRVO, then neovascularization of iris and glaucoma. Then vitreous hemorrhage, can occur in case of neovascularization in retina.
Okay. Okay, sir.
Adem sir.
See, the overall the presentation was good. I was impressed with the way she was reading the case sheet. Right. Anything? You're asking me to ask questions, right?
Yes, sir. Yes, you can ask, sir.
Now, what? Can't you go ahead with an anti-VEGF or any other thing, intravenous injections, with just this the case report that you have made, and also a clear-cut macular edema as seen by the OCT? Or do you want to do extra investigation? You said about OCTA, angiogram. Do you need to do all that, or can you go ahead with an injection?
We can plan of
See, the diagnosis is very clear. You are told, no, it is no RIPD, but there are signs of CR vivoso, which is non-ischemic in type. So can you with that, can you do an anti-VEGF injection, or is justified, or should you go for further investigations? Choroid will be normal, as Madam said, will be normal, but this is with chronic hypertension. They can show L6 pulse and some changes in the choriocapillary level also, because that is part of the systemic circulation. But with this bare minimum of physical examination, if you're very sure, and with an OCT, can you go ahead? Just a question you can answer in any way you like, You said, no, it is not enough. I'll go for further investigation. I want to know more about it. What more do you want to know about it? By angiogram. See, the angiographic findings, the regular fluorescein angiographic findings are read in a different way than the OCT. Both give different views of the vasculature, right? So along with the OCT, you can also go ahead with the OCTA. Do you really need an angiogram for further treatment? Or what is in your mind while doing an angiogram?
Angiogram, it can determine the amount of non-perfusion area we can find out. And we can see whether the amount of visual prognosis, and we can also determine the follow-up treatment based on the angiogram finding.
Which drug will you choose for intravitreal injection here? Vein occlusion.
Ranibizumab.
Ranibizumab. What if the where do you want to work? Can you use can't you use steroid here for vein occlusion?
Yes, sir, we can use.
So what investigation will tell you whether to choose a steroid or an anti-VEGF?
Steroid, there is a chance of cataract and IOP rise. We can do fields.
How will you choose? No, you can choose both. No, either of them in vein occlusions. So what investigation will tell you to choose steroid over the anti-VEGF, or anti-VEGF over the steroid?
Don't know.
It is very evident now by asking you that question, and Papa is smiling.
Field testing to rule out glaucoma.
No, that is where you want to do the angiogram. So if there are large areas of ischemia, you choose an anti-VEGF, because and as you said, now if you leave it like that, patient can go in for a restenosis and ischemic change. So larger areas of ischemia, then you choose an anti-VEGF. It's mainly it's a spongy edema without much of arterial or constriction. You choose a steroid. Steroid is also very effective. It is in vein occlusions. So that is where you need these further investigations. Anything else, Papaji?
China, and though you can't come to the slide show, you can come the down arrow twice, so that will reach the. You can press the down arrow for the slide twice, so that will reach the history of present illness. But yeah, usual slide arrow. Move ചെയ്യുന്നേ നിങ്ങളുടെ ഇവിടെ എന്ത് സ്ലൈഡാ കിടക്കണേ?
പവർ പോയിന്റിലെ
start this the download it's the download
Okay, if it's still not moving, okay. So now why wanted is when you said the history of present illness, no, you said the patient gives a history of defective vision 3 weeks back, then 2 weeks back something happened. So the ideal, so it should have sounded nice if you say that the patient presented with a sudden onset of defective vision in right eye 2 weeks back. And after that you say that 1 week prior, the patient also gave a history of this. So it should sound more logical than saying that patient had a history 1 month back, then this 1 week back, then he developed. So those small things, no, when you present, it will look nicer. That is one thing. Second thing, and also regarding the so since I cannot see that slide, I'm not very sure. And also in CRBO defective vision wouldn't be that dramatic as an arterial occlusion. So you can say that 2 weeks back, what happened? So the patient noticed defective vision, which probably started in this way, progressed over this many hours or days, and 1 week prior, and that 1 week prior history, no, that too, if you ask carefully, the patient said he had 2 to 3 hours of blurring, is it? Was it a blurring? Was it a total amaurosis? So that history should be very definite. When you ask again, no, the patient says that 2-3 minutes. So that history should be very, very, very definite. Maybe it is 2-3 hours, but the history, when you take the history, no, those things are important. And 2 to 3 hours of defective vision, no, if it is a total amaurosis, it should be something like if it's an arterial occlusion, it will be something like an embolus which got dislodged over a few hours. But here we are talking about, then again, we're talking about an vein occlusion. So if the other one, was it an incidental thing? That we do not know, or was it a spasm which passed off? He had a carotid bruit. So that history, you know, it should be more definite. Because always, you know, in history, you should now what is happening is we spend time more on investigations and analyzing the investigations than asking the patient what the history is like. And many a time history tells you a lot more than what the investigations may tell you. So the investigations tell you only the sequelae of the disease process, whereas the history will tell you what actually happened and how you go about it. So that is important. So that history, that slide should have been better if you put it otherwise. That is one thing I felt. The other thing is you said that in the summary, you said that the anterior segment is normal. So anterior segment is normal. A pupil was abnormal, no. So then that doesn't. So contradictory aayittulla karyangalodum parayirudhu. So some people may ask you only you presented 2 or 3 minutes down your presentation. The examiner may tell you, you tell me the summary. So in that case, if you say that the anterior segment is normal, so you are telling a controversial thing about an anterior segment finding, which is very significant. So pupil is a very, very significant thing. And you said in summary, the anterior segment is normal. So these things are very important. Okay. So each slide, each thing you talk about, no, it's relevant.
Okay, sir.
Yes.
See, I don't know whether my PGs are listening. You should never compartmentalize. You ask the history, then you examine, you arrive at a you arrive at a diagnosis with all the photographs and all. It hardly takes some 10 to 15 minutes to do that. Then you go back again. Don't stop there. You have made a diagnosis. Then based on that, you retrace the history. You ask the patients more questions, like the policeman asking questions to the robber and getting the diagnosis out. Like that you should do. So you go back, rewrite. The TIA will confuse you, so you just omit that. So this is vein occlusion, and TIA is an arterial occlusion. So if it is not relevant, just simply don't tell that, right?
Okay, sir.
Otherwise, you cannot explain everything with the finding.
Okay, sir.
So,
And,
findings are very clear. It is CRV occlusion with macular edema. And so you go back into the history for more details of that. Many conditions can cause vein occlusion, even blood sludging, or that like that. So many mucoviscidosis. So many things are there. So you can go back in the history and ask that. Unilateral, of course. So we are more concerned about hypertension and the CRV occlusion. But one small thing I found, you said there is bionetting of vessels, nasalization with a more than 0.6 cupping. So I actually thought you are going to tell it as a POAG with terminal stage vein occlusion, but you never mentioned about that final diagnosis. There's no but when you describe the fundus, you told specifically nasalization of vessels by the 0.6. So again confuses. So your TIA has confused us. The fundus finding about the disc has confused us, and the final diagnosis doesn't mention anything about the probable glaucoma.
And another thing, no, Moisena, another thing, no, when Madan had asked you whether to inject steroids or anti-VEGF, no, in a venous occlusion, you should be able to say why each thing is important. If it's an anti-VEGF injection, or what is the other benefits that you get other than the steroid. So you should be able to tell that, because especially in a CRBO, if there's an ischemic component, no, the anti-VEGF has got its own special role. So you should be, when such a question is put forth, you should be able to say why anti-VEGF is better, why steroid is better, and in an ischemic CRBO, why between these two things you will choose. Okay, so when you answer a question also, you should be a bit more diligent.
Okay, sir.
You see, these are the questions where you should immediately come out with those. This study shows anti-VEGF is better, or another study shows steroids are better. Like that, you should come out with that if you have read about them.
Okay.
And I'm sure Chaitanya they would have discussed with you all those things. You would have taught about those things. So many studies and protocols have been produced on that. So you should also come out with that. So you can actually show your knowledge to examiner when such a question is asked.
Okay, sir.
Anartham, Papa.
Anartham, sir.
Elizabeth.
Oh, yes, sir. Yes, sir.
Okay, sir.
Okay. Can we conclude?
Yes.
Okay. Thank you, Papa, Madam. Thank you, Mohsina. Thank you, Swamin, sir. Thank you, Mahadevin, sir. Mohsina, you did a wonderful presentation. And
yeah, no doubt. I was very impressed by the way she read the whole thing, whole history smoothly. The descriptions were very good.
Papa Mada also, thank you. Next, we'll have the discussion next month. Till then, bye.
Thank you, ma'am.
Okay. Good night.
Good night.
Yes, thank you, Elizabeth. Thank you.
Thank you, ma'am. Thank you, sir.